where's your background with your education? Where did you get your schooling?
So I am originally from California, San Francisco Bay Area, born and raised there until I graduated.
San Fran.
Yep, went all the way across the coast though for undergrad. Went to Howard University in Washington D.C.
Wow.
And then I went to L.A. at UCLA. Charles R. Drew was where I did my medical school training. And then I went back to the East Coast, Pennsylvania.
You like to travel.
Welcome to Posture and Purpose, where both healing and community come together. Make sure to subscribe on Apple, Spotify, and YouTube. Let's get into this episode with Dr. Michelle Carr-Frank.
Hello and welcome to this episode of Posture and Purpose. Today I have Dr. Shaunda Grigsby. She is a breast surgical oncologist here in Lafayette, Louisiana. And I would like to pick her brain about all the many hats that she wears and how she helps all the people in our community. So welcome, Dr. Grigsby.
Thanks for having me.
Thank you so much. Thank you for being here. So tell us, what led you to this pursuing general surgery and a subspecialty in breast oncology?
Good question. So that was, I am a person who has to do things with my hands. I learned that from the time I spent with my dad building things, making things in science projects. And so then as I grew up in life, I figured I wanted something with my hands. And so then healthcare kind of became the place I landed, and it was because of different experiences, friends who had been in car accidents. I got to be able to see their plastic surgery journey, for example, or and so then I told my dentist, surprisingly, that I was thinking about doing medicine, and somehow I thought about anesthesia. That was where I started, and then he let me work with a pediatric anesthesiologist that would come to the dentist to do stuff with kids. So I did that for some summers while I was in high school, and then
high school.
I know,
so young. That's great.
And then I ended up just kind of diving into what more of healthcare was, and then I landed on surgery. I think more so because of the technical skill set and the ability to build and do and take and and put stuff together. And I kind of always thought the puzzles were great, and so that's just really where I think it spawned from.
Yes,
and then when I got into
young age,
and my mom always asked me, like, there was nobody that I can say told me to do that. I kind of just decided I was going to do that, and that's where I went. And then I got into general surgery residency and started to spend a lot more time with people being diagnosed with breast cancer. A lot of my people I worked with, the nurses and the staff that I spent a lot of time with. And so I started to get more and more involved in what breasts look like and building a breast program at the surgical hospital that I was at. And then did a couple months at Sloan Kettering just to get an idea of what it, like that big research, very strong breast program that they had. And spent 2 months there just kind of understanding that. And I felt like that was where I wanted to be. I like people. I want to take care of people, but want to get to know them for a long time. So I feel like that was where breast surgery became a part of my dream.
And
so
took you.
I'm here now.
And that's where it took you. Now, yes. I know you wear many hats. Can you tell us some of the other things that you're involved with?
Yes. So I'm actually the Associate Regional Medical Director for Austin Lafayette General Medical Directors, medical doctors in the clinics. And so I do a lot of oversight of employing our physicians and APPs within which are our advanced practice providers, so nurse practitioners, physician assistants, CRNAs, and that's the big part of what I do. It's part of half my job. So
sounds like a big job.
It sounds like a big job. It is a big job, but I enjoy both my breast surgery and my administrative roles, and that's been kind of my journey for the last 8 years.
And how does your background as a general surgeon shape the way you approach breast cancer services or breast cancer care? Because general surgery is broad. Mm-hmm. So I know you said you spent some time at a research facility. Mm-hmm. 2 months doesn't seem like a lot of time. So was it just something sparked a passion in you to do this?
I would say, so when I was in high school, one of my friends' sisters was diagnosed with breast cancer right after she graduated law school. So young, 37, 40, years old, and didn't really do well. She didn't survive, and it was a very quick process. And so I think that always stuck with me in the back of my head, I think, while going through general surgery residency. And then for me, it's the relationships, the building of relationships. And I'm just a very big, I feel like you could be a jack of all trades or you could be good at one thing, right? And so I enjoyed general surgery. I enjoyed doing thyroid surgeries and all the things that general surgery had to offer.
Right.
But I also thought about my personality and what I felt like I was going to give the most to. And so breast surgery became that thing. So in general surgery residency, I spent that time learning about it, understanding it, going through the imaging side. So learning how to do the ultrasounds, the biopsies, and looking at imaging with the radiology team. And then when I went to Sloan Kettering, it was for gaining understanding of, do I need to do a fellowship or not, right? That was the other part. My general surgical training, I did all the breast. So that includes the breast cancer part, the plastic surgery part, because we didn't have anybody besides general surgery residents, no fellows. And so I did a lot of that. And then I said, yes, I should probably do a fellowship. So then I went up to Beaumont, which is now Corewell Health in Michigan, and did a 1-year fellowship in breast surgical oncology there. And then I came down to Lafayette, Louisiana, and started practicing as a breast surgical oncologist here. And that just really stemmed from wanting to make a difference in the breast world, and going to a place where I felt the diagnosis rate was pretty high, and I felt like I could make an impact of all the things that I had learned, and bring it to the community. And
it's not for everybody.
No, it's not for everybody.
You know, I mean, you can be a general surgeon,
yes,
but it takes a different personality. You have to have that relationship, like you said. Yeah. And what do you wish every woman out there understood about breast health before they ever need you?
Yeah, good question. I think the biggest thing that they should focus on is just understanding the screening and prevention part, right? And then knowing your family history, because I think that plays a bigger role than we ever thought it would. And over the years, we've learned so much about that I think genetics is a big part of what we do. And I think it will be where we go in the future as far as how we treat and manage diseases. And I think we'll have so in breast world, we already have a lot of good outcomes, right? We a lot of research is in breast, and the survival rate is extremely high, right? And I think that's the first thing I'd like to tell people. The survival rate is really high. The point, though, is finding it early, right? And so, but the treatments have advanced so much that it's getting more targeted towards the type of biology that's within the cancer itself. And that is going to be a big game changer over time. And it already has been, as far as response to therapies and how what people do, right? So I always tell people the first thing is know what screening is, get screening done. Finding cancer early saves lives, and the survival rate for breast cancer is extremely high. So fear is something that I understand people always have.
Sure.
But the goal is to get it out and to move on with life and not dwell in it.
Face
but
that
I think
fear.
Face the fear. Because I think a lot of people don't want to face the fear of, yes, I have the word cancer. The C word is a big word.
Right. The unknown, too.
Yeah,
like, what's ahead?
What's ahead?
What do I have to, fight with this challenge on this, and what life has brought to me? So what about benign breast conditions? How do those differ from other situations that might need cervical intervention?
Yeah, so essentially, there's a wide span of benign diseases that people will come across. Some of them are cysts. They cause breast pain, right? And we do a really good job of trying to help people understand what that breast pain is and what it's about, and how to manage it. It could be a bra fitting appropriately. It could be using some topical anti-inflammatories. I tell people, you have arthritis medicine. It's called Voltaren gel. It works great for breast pain. And so just understanding breast pain, and then understanding benign lumps, right? Because lumps are scary, bumps are scary, right? And so you, as a younger person, tend to have a lot more breast changes happening as we go through different hormonal cycles throughout our aging. And so you might have more of what we call lumpy, bumpy breasts, right? And so how to be aware of what that feels like. It makes an exam kind of difficult, I think, when some people are doing home self-exams.
Sure.
But I think just being aware of those benign lumps and bumps that do exist, also making sure that you're aware. We do ultrasounds to make sure they are benign, because we do see cancer in younger age individuals. But there's a lot of different benign processes out there. Some of them may put you at higher risk, some won't. And so our job is to make sure that we educate somebody on what that is. And so if someone has a biopsy done that shows, let's say, some atypical cells, what does that mean? What does that mean for me, and what would I recommend and do? What would I do from an imaging perspective, and what would I do from a management, either surgery or not surgery, but maybe I'll give you medication to lower your risk. So that is just where we focus on. We have a benign breast clinic as well as a high-risk breast clinic that are run by our physician assistants that I pretty much educated and taught, I guess, from the ground up. But I think that that helps us to help educate our patients on what to expect from their results, and what to make of them, and how does that impact what they do going forward.
And where's your background with your education? Where did you get your schooling?
So I am originally from California, San Francisco Bay Area, born and raised there until I graduated.
San Fran.
Yep. Went all the way across the coast, though, for undergrad. Went to Howard University in Washington, D.C.
Wow.
And then I went to L.A. at UCLA. Charles R. Drew was where I did my medical school training. And then I went back to the East Coast, Pennsylvania.
You like to travel.
Where I did my general surgery residency for a 6-year training. And then I went to do a 1-year fellowship in breast surgical oncology. And then that was in Michigan and came down here. So I kind of been all over the place.
So where do you call home?
Well, now this is home. Between here and California is home.
Okay.
And my parents are from Louisiana, from Shreveport and Monroe
good.
area. They live in California still, but
they
come visit me all the time, and they are here all the time.
Are they coming in for the holidays?
They're not this year. My niece and nephews are going to go visit them, and so everybody's going to California.
Gotcha.
So we kind of go around between there and I guess California.
Take turns.
Yeah,
exactly.
But yeah, so been kind of over the globe. I've met a lot of great people.
Sounds like it.
And
We're so lucky to have you here.
It's been a great journey, and being here has been great. I've enjoyed the community, the people, the culture, and I enjoy the patients that I take care of. It's a
very special.
It's a community that's very special.
Absolutely. And people, we talk about facing the fear. What age should someone? I mean, this is such a big thing. I don't need to get my first mammogram until I'm 40. But what age and risk factors should guide someone's decision when getting screenings?
So the first thing I always tell people, that's where history comes into play. So if you have no family history that you're aware of breast, ovarian, or any other cancers, to be honest with you, our high-risk program actually looks at all risks. That includes colon cancer risk. But if you have no risk of the breast or ovarian, for example, or the main two that we kind of focus on from a breast perspective, then you're probably at what we call average risk of breast cancer. That's usually 1 in 8 women, so 12% risk roughly, give or take. So usually that's a screening start about age 40 at the present moment. So we recommend screening age 40 from the American Society of Breast Surgeons, the American College of Radiology. The United States Preventative Task Force will say a little bit differently, maybe starting at 45, but consider starting at 40. But the rest of us are pretty hardwired.
Okay.
Okay.
I just wanted to make sure I got my numbers right. Okay.
On age 40. Now, if you have family history, we always recommend doing a risk assessment, whether that is through your OB-GYN's office or your primary care if they do perform it, or you're more than welcome to go online. We have some online platforms that will let you kind of put your history in, mostly focusing on menstrual cycle, when it starts, how many children you've had, live births, age that starts, and then adding family history into that definitely will bring about some different risk, I guess, profiles, depending on how young the person was in your family and where they were. So, mom, your aunts on either side. If you've had cousins from an aunt that has, if the aunt and the cousin have cancer, then it's the same, mom and daughter. That's concerning. So we like to understand that. And then, and if you have any biopsies in your past, sometimes biopsies, just having a biopsy can actually up your risk. And so we're looking at all the information to determine whether someone should have something done earlier. So if you have a first-degree relative, which is your mom or your sister, with a diagnosis of cancer, we want to know what age. Because then, let's say you have somebody diagnosed at 35, then we may tell you you at least want to start your screening mammograms at age 30, but you might want to be you might be eligible for MRI of the breast by 25. So it's just some of those things that we can educate on, but it also it just depends on a lot of those kind of factors that I just mentioned. So we take all that into account when we see people come through the door. We can all fill that information out so we can understand where we're starting from.
Yeah, it's like putting together pieces of a puzzle, a roadmap with genetics, because you know we can't pick our genes.
Nope.
We gotta play the hand we're dealt.
Figured out.
right. And so we talked about tools like mammography, ultrasound, and MRI. So someone wouldn't go straight to an MRI unless there was some type of family history.
Generally, yeah.
Generally, okay. And how do you advise women who are anxious about mammograms? And they're scared, and they want to avoid screenings out of fear. We talked about that a little bit, but is there some push? How do you get that through to them?
It's tough. I don't always win the battle. I'm going to be honest with you. I don't always win that conversation. My ultimate goal is just to tell people, a lot of times the fear of screening is the pain. Right? Mammograms can be painful in the sense of the compression and things. So I always tell people, just communicate with your mammo tech, the mammography tech that's doing your mammogram. Like, let them know, hey, look, I'm trying to get through this mammogram. I didn't have the great experience last time, and I don't want to have the same experience. And so you just let them know ahead of time. And I think you'll find that the mammographers are very accommodating to that. They don't want to hurt people. That's not the goal, right?
Right.
The other thing is, people don't want to know, right? Not knowing doesn't, and tell people not knowing doesn't prevent it from growing and doing what it's going to do. So what we hope to do, and where we find the best outcome is finding it early, right? Small. I don't want you to feel it. I don't want to wait for you to feel it. If you're feeling it, maybe not the best. Obviously, we do have advancements in healthcare, and people do okay. It's just we prefer not to feel it. We prefer to find it on imaging,
or not find it,
or not find it at all.
Right?
Exactly. And so it's just really trying to talk through the fears. My biggest goal is to sit down and communicate about the fear. Again, I go back to don't sit in the fear. Let's talk through it, and I'm hoping that through that conversation we ease that fear, right? And so I spend time having those conversations. Radiation exposure and things like that come up often, and I'm like, look, we live by airports. We live in a place where there's radiation exposure every day you go out your house, and so the amount of exposure you get for one mammogram does not even equate to the amount of exposure you get on a daily basis. So I understand that fear, but it's really not something that we can say is true in the sense of causing cancer. I mean, at this point, because you have people who've never had imaging done before, and here they are with a cancer before they show, at age 37, right?
Weigh out the risk.
Yep. Risk benefits. You're right.
Yeah,
exactly.
absolutely.
Risk benefits are definitely
important. And I know you mentioned plastics.
Mm-hmm.
So what are the biggest misconceptions about breast cancer surgery? Okay, we all have an idea of what that means and what that looks like, but can you take us down that?
Yeah, good question. So I think some misconceptions that I always like to address are when we're doing cancer operations with reconstruction, it's reconstruction. It is not cosmetic in the sense of the word. We hope that we get to a space where it looks and feels normal as possible. But remember, I tell people we have removed something, created an empty space, and we're trying to fill that space back so at least have a shape and a look that is normal. It won't be reconstruct. It won't be cosmetics, right? It's not like we're going to keep your breast intact and then we're going to put an implant to enhance something that's already there. We are going to try to replace something that we have taken away. Like I have taken that away, right? And so I try to get people to wrap their mind around that part. I do think from a surgical perspective, certain people might choose a surgery thinking that it's going to change the overall outcomes. And a lot of time I tell people the risk of a cancer coming back, whether you keep the breast, do a mastectomy, which is taking the breast, generally it's probably close to being almost similar majority of the time. And it's not zero just because you've taken the breast in a mastectomy. So those are some of the conversations I like to have with the patients because it's different. I tell people when we take the breast, it's different. It's gone. You don't have sensation. I just want people to be mentally prepared for that change. Sure. Because it is a change, and it's different versus what we call a lumpectomy, where I'm just taking a lump of tissue out, and your breast is otherwise shaped and looks the same. And but those are two different things, and they take two different psychological tolls.
I was going to ask you about I mean, you're a therapist as well.
Oh yeah, it's a psychological toll that I think people sometimes aren't all the way prepared for. Yeah. And I do try to make sure they are prepared because it's different, and you'll have people who don't realize that they have a belly that they've had, and it's some of those conversations, and I try to mentally prepare for those if we're gonna do a bigger operation. And then reconstruction, we use it in people who are getting what we call lumps. I believe in the what we call an oncoplastic reduction. So someone who may be large-breasted, who's going to get a lumpectomy, we can then do the reduction, the lift for those patients if they come out really pretty and they look good, and we've been able to take a good margin around that cancer. And but I say put your breast back in a pretty envelope. Now that is a good operation, right? We don't put anything foreign. You're not getting a big flap, what I call flap surgery, which I'll talk about in a moment. But it's a pretty operation, and it does do a good job of what we need to do. When we talk about reconstruction from a mastectomy, where we're going to take the entire breast, then you're talking about a different type of process. Is that process going to be implant based, and then the risk benefits of implants, and then is it going to be a flap procedure, which I just mentioned, where we're taking tissue from someplace else on your body and putting it in to fill a gap in the breast, and that could be two different outcomes, two different risk recoveries, all different, right? Sure. So weighing those pros and cons, right? And so I always make sure people are weighing all the pros and cons, kind of really have a true understanding of what they're getting into with others, whichever way they choose to go. And I'm a believer, like you would find a lot of breast cancer surgeons in our society. We talk about, mastectomies are something people think they need, but not necessarily what do they need it? No. But I'm also kind of the mindset of it's a personal choice when it can be. I say when it can, because sometimes it's not the best option overall for whatever the situation is. But
It's such a personal
it's a
surgery.
it's a personal surgery. I feel like while we as physicians can try to put our science is a part of this, and we're not supposed to quote unquote treat anxiety, right? Like with surgery and things. I said, but I'm also a quality of life advocate. So whatever quality of life makes sense for the person. Like if you lose sleep every night, if you are nervous,
mental,
yeah,
the mental aspect of it. It's such a part of womanhood.
Right,
I mean, it's so personal.
It's so personal. So I said, I try to take a personal approach to that with the patients, so that we're making decisions together. I'm not making decisions for them. I'm here to give you information, talk the information with you, and give you my feedback. But at the end, the ultimate choice is generally theirs.
So what have you seen? What changes have you seen with recovery since you've been practicing?
Oh,
I'm sure, new technologies or new procedures.
We've definitely probably moved more to a true outpatient, meaning people go home the same day from a lot of the procedures that we do when we normally would keep them for several days. We recognize that, lumpectomies, we tend to send people home. Mastectomies were the ones we kind of kept people overnight, didn't keep people overnight, but the pain medication we give is better. We use longer acting locals that can be, can numb things and kind of, make that recovery process better. We've learned certain medicines that work during certain surgeries that impact nerve pain, and so those are just some of the things we learned over time to allow people to recover at their homes, because sometimes it's not the best recovery when you're not at your house, but
you can relax. You can just let loose and relax.
Oh,
sure.
And just learn how to communicate with patients about their post-op care. So if somebody's going to have a mastectomy and they can't use their arms as much, I'm like, get a recliner, and we talk about all these things. Help yourself get out that bed out of the chair without using your arms as a risk to bleeding and all those kind of things. New things that our cancer survivors are doing. We have a company called Knitted Knockers that make breasts that are made out of a certain type of yarn, and they are a company that's nonprofit that as somebody's healing, they're not ready for a bra or prosthesis, for example, but they are comfortable, soft, and you can put them in the bra while someone's healing.
And that's local?
It's local. So there's a local group, and there's a national group that we work with, and they supply our office with that. And I think that is, you should see some of the patients' faces when they're like, I'm still healing, and I'm like, so we go get them, and they're like, thank you. And it's very just those small things.
The small things make a huge difference.
Small things.
Oh,
and survivors have done great stuff. They have a survivor who made a company with nipple tattoos that are the pasties, kind of like the tattoos you used to use when you were a kid, where you would put the thing and the water would go on top, and it would just sit there, and it would be there for 2 weeks.
Yeah.
So she made a 3D nipple tattoo that they can stick on and keep on for a couple weeks, and I mean, just
the mental,
all the things.
It really is, and realistic expectations.
Yes,
They have to know. Look, this is not going to be fun, but
Correct.
we're gonna face it head on, and we're gonna be here for you every step of the way. So, how does a breast surgical oncologist collaborate with other medical oncologists? Because I know you're a surgeon, but how does that work alongside other oncologists, radiologists, pathologists, radiation oncologists? I mean, there's just such a team behind what you do.
Team approach to everything, and that's the one thing that we preach. So we call ourselves the multidisciplinary team, right? So we all across the disciplines, radiology, medical oncology, surgical oncology, radiation oncology, all involved. So what we work to build is that process, and we're working on building that now actually at our clinic, where we have people who meet certain criteria that need to see all of us as providers, and how do we do that in a day, right, in a time. Right. And so that's kind of what we call our multidisciplinary clinic, and so that is something that we work across. We have tumor boards where we talk about all the patients that have had cancer diagnoses. We talk about their pathology, imaging, management. We use our guidelines, so a lot of us follow NCCN, which is our cancer network guidelines that are kind of nationally provided and given, and take a lot of different people's inputs from across the nation. And we use those kind of guidelines to judge kind of where we're going from a treatment perspective. And so we talk about the patient's care and who needs radiation, who needs medical oncology from the sense of chemotherapy, or who can take a aromatase inhibitor pill or tamoxifen, whatever that is, for risk reduction after surgery or after final treatments. And so we have a big group collaboration that talks about all the patient's care together. And
how often do they meet?
We meet every other week right now, and then we have I'm on 2, which is tricky because we have, so I essentially go to what we call breast tumor boards every week, But
Wow.
it's a group of providers coming together who take care of all the patient globally, and we talk about each patient and go through all the images and make sure we're all on the same page.
Well,
And,
being that you don't sit down or sleep because you do so many things, how do you stay healthy? What is your
Oh.
favorite outlet to get out and
Yes.
just release some of the stress of all these things that you do?
Yes. So there's two outlets for me: physical activity. So like I like to do kickboxing. It's one of my favorite things to do. So I have kickboxing in my house.
You have to bring it home.
Oh
with
yeah, I
you.
have to bring it home. I get up too early now. I used to be able to go early in the morning and come back home. No, I have to do it at my house now. But I do have my home gym and things that I use, and I have 2 dogs, so my dogs keep me pretty busy. My little fur babies.
What kind of dogs?
They're cockapoos, cocker spaniel and mini poodle mix.
Oh, I love
Piper and Prince, both males. So they keep me busy and going and laughter, and they're hilarious. So that's my physical kind of stress
Yes.
relief. And then my other mental really stress relief is I like to paint. So like I said, I like to do art and build things and create things, and so I like to paint.
You're still doing it
I
from
still-
childhood.
I still
You
do
watched
it.
Dad do it, and now you're doing it as a
Still
career.
do it.
But you have that outlet artistically, so that's
Yeah,
cool.
So make different canvases and work on sculpting things and just random stuff like that. But that is
Everybody
those are my
needs
two-
an outlet, that's for
those are my
sure.
2 things.
What role does genetics play in determining a surgical plan? You mentioned, we briefly touched on genetics, but could you go into that?
Yeah, oh yeah, absolutely. Genetics can play a big role because what we've learned recently or the last couple of years is I call it the Angelina Jolie impact, where people really knew about BRCA1 and BRCA2, so our breast-related cancer genes. Those are the big 2, the heavy hitters. But there are actually 10, 12 probably that are probably more than that actually associated with breast, but other types of cancers, right? That put you at risk for colon or stomach or skin melanoma. And so that was something that we recognized early on after my arrival here. I mean, I actually did quite a bit of training in that. That was part of my fellowship training. They had a whole genetics department that was training physicians as geneticists. And so we spent time in those clinics to understand the genetics. And so I think coming here, that was a big part of what I did as far as assessing risk. But then it's risk plus genetics. So you meet criteria for genetic counseling. Because there's risk factors that put you at elevated risk that aren't necessarily familial. It could be the biopsies that we talked about before. But if it's your family history, that's really where you dive into the true understanding of, man, this person may have something that was handed down to them that they have no control over, right? Like you said before. And so we started to go down that road. We already had a genetic counselor on our campus and one of our nurse practitioners. And then we just grew so big in the sense of how many people who we would assess for the criteria and, working with insurance companies and things.
Sure.
Over time, I think being advocates of that has helped many people drive down costs and then increase access to genetic counselors and genetic testing. And so over the years, we've definitely grown that program, and we have 2 genetic counselors on site for us, and one that does only breast, and then one who kind of does all the other, I guess, cancers that we see. Because there's colon cancer-related cancer genes, there's pancreas. I mean, it's a lot. And so, getting trained in genetics is kind of what me and my partners who work with me have done.
It's such an interesting field.
It's so interesting. It's very interesting. And I think from a surgical perspective, and when how's it impact surgery is sometimes, yes, that's when we would do more in an operation than if someone with the same disease presented with maybe early stage breast cancer, for example, that I would say a lumpectomy and radiation would be appropriate for. But if they were at elevated risk for breast cancer overall, then you're talking about maybe a bigger operation, which is a bilateral or a double, both breast removal. And then you're talking about ovaries a lot of the times, depending on the gene. You're also talking about radiation risk. So some genes can impact someone's ability to, not the ability to have radiation, they can still get radiation, but they know they become more sensitive to it. And that can impact what their skin's going to do. And so you know that now. So it puts them at risk for breast cancer, but it also makes their skin more sensitive to radiation. So you kind of you want to have an understanding of that when you're operating, because you don't want to say, hey, you're going to do this lumpectomy and get radiation. They have to know that that's a risk to do that, and
Major change.
that can change and put you at risk for another cancer down the line, right? And so we have to have those conversations, and then you'll have cancer risks that put you at risk for some of the more, maybe a little bit more scarier cancers like sarcomas and things. And so you're just trying to make sure now I got to do full body scans on this person. Now I got to check their head to toe constantly, consistently. And it's not just the breast that I'm looking at. I'm looking at all the things about this person. So I think it definitely can impact what I do surgically and what I would recommend surgically, or what I would at least counsel people on. I always tell people, these are recommendations. Even if you have a gene and the risk is there, whether it's 60%, 70% risk, it's your decision again, that if you want to do the bigger operation, i.e. the removing both breasts versus just a lump. Like, you can still absolutely do a lump. If somebody finds out they have a mutation and they're 65 or 70, they're probably thinking, maybe do I really want it? Some people do, some people don't. Everybody's a little bit different.
Right.
But it's just being aware. And then it's also the awareness that it brings to your family, right? Because if you have a mutation, then your family members might want to understand and know better about what that means for them.
Earlier
so
prevention.
They can be, early prevention. Yep.
What do you feel? How do you feel about the full body scans? You know, is it Pronova?
Oh yeah.
What do you think about those?
I mean, I think it's got its pluses and minuses. Everything has pluses and minuses, right? Because we're scanning people to find things. Again, creates anxiety.
It does. Yeah.
And again, what you find may or may not be a cancer, or it's one of those things. It gets a little bit tricky.
It does, because then you have something else to worry about, but it's really not worth worrying about.
Right. So I think about that sometimes with breast MRIs too, right? Because I tell people breast MRIs are very specific. I mean, very sensitive, but not specific to breast cancer. So we might find other things that we bring you back for and investigate that aren't going to cause you harm. But now, like, your spotty senses are up and everybody's kind of
anxiety.
Yeah. So I think whole body scans have their place. It's always that anxiety thought in my mind of like, okay, now we're going to be chasing things when we wouldn't necessarily be chasing, and they may not ever cause you harm. Like, and it's just,
I know.
It's again, people's choices to understand. As long as they understand those risks, pros and cons. Realistically, yes, and people should take that in.
That's the balance.
And it's like, what do you do? Who's going to follow it up? Who's going to, but yeah, so.
And how do you become, how do I say this, good at delivering bad news? I hate to be on a down note, but how does it feel, or how did you become better at delivering difficult news to patients?
I don't know if people ever really become good at delivering.
I wondered if it just, do you become
news,
kind of immune to it?
Never immune. You're never, at least I can speak for myself, I guess I should say, never really immune to it. I think, it's never really easy to give people news that this is not going well, or, this is where we're going to end up. I think no one ever likes doing that. If someone likes doing that, I probably think we probably should go talk.
Take a vacation.
Talk about that, But I think it's never really easy. I don't think it ever gets easy. I don't think you can. It's always going to be based off the person you're talking to, because everybody takes that information so differently.
So many different personalities.
And so I don't even think you can use one situation to prepare for another, because
hard to navigate
altogether. And you try to figure out how, it's like, how do you still inspire hope at the same time, right? And that's really where it becomes tricky for me, because I feel like inspiring hope is still a good thing. I think people think, we talk about this quite often, like going into palliative medicine is not hospice, right? It's just putting someone can live in palliative medicine for years, just to be aware of like what's happening. So like someone's breast cancer that is progressing doesn't necessarily mean it's progressing in a rapid space of where they would be not here in 6 months, right? I think it's more of this is what's going to happen to the skin, this is what's going to happen to this, but it doesn't necessarily try to harm you that quickly. And so like you're living in that.
Yeah.
Right? But it's still not good news, right? You're like, this is not going the way we want it to go. But there's nothing else I can do from a surgical perspective, or that I can do from a chemotherapy perspective, right? And so you're trying to navigate that conversation and keep them comfortable in life as they go through life, because that life could be as long as time clocks just don't.
You just don't know.
You just don't know.
You don't know when your time is here.
Yeah.
So are there support groups that you really focus on or reach out to or direct your patients to emotionally or physically?
I would say, there are. I think really there are some of them support groups here locally. There are the larger ones that are kind of out there. It really is kind of, what's surprising in the breast world to me is that people know so many people who have gone through.
Isn't it?
It's like,
in Louisiana.
Yeah, and they make their own support group in reality about what this looks like. But Miles Perret has a really good one. They meet. We work with them. They give us calendars. We sit with them, and
they're great.
And they help us with the mastectomy boxes, and we pour ourselves back into them. And I sit with them on their supplies committee, and a couple of us on the board. But like, we work really close with our community. We have a lot of the Young Survivors coalitions, and that's a whole subset of different things that people are dealing with at different ages when they're diagnosed. I can tell you, those who have those young kids at home, it's a struggle. They're trying to figure out how do I tell my kid, and you're trying to let them help them navigate those conversations. So there's just differences as far as what people need from those survivor groups at the time in which they are diagnosed. And so the Young Survivors Coalition, there was Pink Ribbon Ladies. There's so many different groups here because there's so many people who've been impacted by it.
Yes.
But I think just finding those that fit your personality, whether it's faith-based ones that are coming from your churches, and there's a lot of different ways to go about that. But if you, I also tell people, if you feel like it's overwhelming to be in those spaces and you really want to talk to people, then finding a good therapist of your own is helpful. I tend to refer people to Psychology Today, where they can kind of scroll through and research themselves of who they think will be a good fit, and then what their insurance will cover. Oh, now, insurances, don't cover everything, but I try to make sure people aren't. My last hope for people is that they're thinking about the financial state of life, which they're going to think about it, but I don't want that to be a reason why they choose or don't choose something that.
And to be an added stress, of course. You don't want them to have to deal with that. Now, talking about reconstruction, how important is mobility, posture, those kind of things? Because I see, of course, many post-surgical patients, and the flexibility, the skin, the muscles, everything as a whole. Yeah. So how does that play a part?
It plays a big part. So I think you're trying to, so when someone's getting surgery done, they scar, right? And I try to, explain to them, like, I need you to be stretching. Stretching is going to be a lifelong part of your life. It's going to be there forever. I'm going to ask you to do it all the time, whenever you can remember. And then when you get reconstruction, it also adds an added layer of complexity, because you don't want people doing too much, depending on how the reconstruction is done, because we don't want people flexing muscles, which I understand, but I'm also very aware of, I need you to move your arms. Right. I need you to stretch your shoulders back. I need you to open up your deltoids. I need you to open up all these things, because if you don't, then it leads to problems down the line. You can't raise your arm. You get what we call axillary web syndrome and pain from just... So my biggest thing is I give them these exercises to do that. I talk to the plastic surgeons about and say, hey, I'm going to give them these exercises. I'm going to call them stretches. They're not exercises, because that's kind of...
don't exercise.
We don't want you to exercise.
Just go through the motions.
I want you to stretch. I want you to open up your chest. I want you to just, And so we try to make sure that they are aware of these. I said, these are two things I need you to do. Walk the wall, and then put your arm in the door and stretch it out. Because I said, you need to open up your chest, because that's where you're going to get that tightness. You're going to always feel tight. It's going to always want to come back to... Yeah. But I need you to not come back to that. I need you to open it up like this. And so we continue to have a conversation, but it definitely needs to be way more ingrained. I think,
yes. In chiropractic too.
In chiropractic. Because all the things, and your posture just all, and for example, people who've had what we call unilateral or a single side breast removal and had a heavier breast on one side, right? That is always something I'm always thinking about, because they were already having shoulder and back issues probably majority of the time. And then when you remove the weight to one side, you can only imagine what's happening to their spine. Right.
There's such an imbalance.
An imbalance. So I'm always cognizant of that. I think that's something that, as healthcare has grown, and when people try to say, well, why would you do a bilateral or double mastectomy? I said, well, I can do that or a reduction. Either way, I'm doing surgery on one side or the other, right? And so it's because of that part. Like, I think people have to be aware of the downstream effect of what we're doing. Yes. Right.
We're trying to prevent future issues later on down the line.
So absolutely have a hand impact on physical therapy and stretching and back in chiropractic, because it's very important.
It is overall for their overall healing time.
Yes.
What are your thoughts on incorporating complementary therapies? Maybe not
alternative medicine
or lymphatic drainage, lymphatic massage, mobility work.
Absolutely.
In any of those things, do you have an opinion on any of those with
my
healing?
Opinion is that they're great.
Okay.
I think they help with. So we deal, we're in a state where we have some people who tend to be a little bit more heavy, and they can hold on to fluid differently. And so
good old Louisiana.
Yep. And they can hold on to it in their arms, in their breast. And I think, and that can create delays in how they recover down the line. And so I believe in we actually just finally took 2 years, but we got our approval for a lymphatic measuring machine that can be more consistent. It's called Sozo. But we've used it in its younger year form, which used to be like little probes you would put on, kind of like an EKG. But now it's like bioimpedance and kind of understand that. But you can understand it from lymphedema of the legs. So we have like the gynecology, oncology surgeries that do a lot of pelvic surgeries, right? And so you can get swelling in your legs. Anything you're doing that takes lymph nodes from any place can cause a
Yeah.
backage and a leak, and a clogging, as I call it, backup of fluid that's now held in your extremities.
Yeah.
And so how do we measure those things? And so we actually finally got approval for the entire system of Ochsner to utilize this machine to help measure.
Good. Okay.
And so that will be, and so we use lymphatic massage. We use lymphatic pumps. We partner with our physical therapy team to get them
Work it through.
and try to get insurance to cover some of those things.
Yep.
I know I talk about that quite
That's a
often. but
whole
it's
nother
it's a whole other
episode.
bucket a whole other bucket of conversation. But
Right.
it's just, so I believe in that. I believe in reverse, what we call lymphatic mapping, trying to find out where the flow is going. So we try to preserve vessels. And
So important.
the one thing we don't have here, which we probably would work on, is lymphatic to venous bypass. Sometimes when you have just those really horrible lymphatic misconnections that lead to really uncomfortable heavy arms and heavy legs, or for that matter. But definitely think using all therapy, in my opinion, is helpful, even from cold caps for chemotherapy and things like that to try to minimize hair loss.
Yes.
All those things. I mean, it's worth trying. I mean, I don't. Sometimes people don't think it works. But there's people who it might work great for them. So I'm not really sure if it's just more of an educational thing, but we need to
explore your options. There are options.
there are
Thank
options.
goodness
There are options
that we have out here.
Definitely options. And so I'm a firm believer in people kind of utilizing all the things at their disposal that they can to help their journey,
Right.
and that's important.
And it's very obvious that you're passionate about what you do. So that's a gift that we have here in Lafayette. So what is one message that you would like to relay to any of our listeners today, any man or woman listening, that you would like to, one message or two or three, whichever.
The one message I always tell people is we tend to want to take care of everybody else before ourselves, but it is important to take care of yourself so you can show up for somebody else in the way you want to. So prioritize yourself. Get your screenings done. I'm not just talking about breasts. Screenings that are going to help to mitigate the quality of life impact if something was found later, right? So that way you can get back to being there for people, right? You don't want to be hit by something that we could have caught early enough that would have spared the quality of life, your ability to be that person for your kids, for your husband, for your parents. And so prioritize yourself. It's okay to do so. People will understand.
Yes, and people will understand. Take care of yourself, and
you'll be surprised who shows up to help you. So
well, that's a very, very important message for sure. So if someone listening today feels a lump or notices a change in their breast and they are in that fear stage, what should they do today?
Let a doctor know. Let somebody know, so that way we can walk you through what the next steps will be, and know that you have a team. There's a team always there, whether you've met me before or your primary care, your OB-GYN, your whoever you have seen. Let somebody know, and let's at least see what it is first before we make an assumption, because there may not be cancer, right? I think the biggest fear is that, but there's a lot of lumps that exist that aren't necessarily cancer. So we just need to make sure we know what it is, and maybe it's not something to worry about. Maybe it is, but if it is, we want to take care of it quickly, so that way it just becomes a blimp in life and you get to move on.
And if someone has found themselves in this situation, unfortunately, how can they receive your services?
Yeah, so we you can contact us at 337-571-1300, and that is our breast center number. It will get you to our imaging side as well as our breast surgical side. But again, we're there for lumps and bumps, pains. If you don't know where to go, we will do an assessment before and figure out what the issues, what you need next, whether we do ultrasound ourselves in our clinic or get you to our imaging side to do a mammogram or MRI. And we're located on South College, right across or right on the same side of Hub City Diner, if you've ever been. But essentially, we could assess anything. We tell people you don't need referral from anybody.
I think that is a very big misconception, is that you need a referral.
Sure. And I think sometimes people do, but even if you have a doctor and you call yourself, we'll reach out to them for you. And we'll say, hey, look, if we really need a referral, we'll figure it out for you. But really, you don't need a referral for an imaging exam. If you need a screening mammogram, we do that with self-referrals. That means you can bring yourself, and we will do a screening mammogram. So we want to take down barriers to care and barriers to timely care.
Right,
So,
and get the care that that person needs so desperately at that time.
Yep.
So, my last question of the day
yes.
is, how do you maintain your posture while pursuing your purpose in life?
I would say, I maintain my posture by sticking to my morals, doing what's right for people, doing what I would expect someone to do for me is kind of how I approach everything I do.
Be a good human.
Being a human, whether it's breast care or my administrative role, just doing it for the right reason, making decisions for the right reasons, being there for people the way you want them to be there for you, and walking faith in that. Like, that's what I do, and so I want to give my best to everybody all the time, and that's how I maintain when I have to make those tough decisions, or when I have to have those tough conversations, and for patients to get them through what they need to get through, and I never leave anybody behind. So I tell my patients, even if we don't believe or agree on the treatment, I still want to see you every couple months so we can talk through what you're doing. I don't want you to get lost.
Right.
And so I say, I won't let you get lost, is what I tell them. So if you don't call me, I'm calling you.
Right.
And we'll bug you until I hear from you. And if that means I'm going to reach out to somebody else, I'm going to find them. Because I don't want you out there lost.
Right. Well, and they're very lucky to have your guidance if they are lost. So thank you
That's my ultimate
so
goal.
much. Thank you for being here today.
Absolutely.
We've learned a lot. I know our listeners have learned a lot. And until next time, sit up straight, stay happy, stay healthy, and stay adjusted.
Thanks for listening to the Posture and Purpose podcast with Dr. Michelle Carr-Frank. Make sure to subscribe on YouTube, Spotify, and Apple Podcasts. Until next time.